You are listening to the PGX for Pharmacists podcast, part of the Pharmacy Podcast Network. Pharmacogenomics is the study of how genes affect a person's response to drugs. This revolutionary science combines pharmacology and genomics to develop effective, safe medications and doses that will be tailored to a person's genetic makeup. There's no better healthcare provider positioned to leverage the analytical power of pharmacogenomics to provide more effective medication therapies and outcomes than a clinical pharmacist. And now, here's the host of the PGX for Pharmacists podcast, pharmacist, researcher, and national pharmacogenetics expert, Ken Sternfield.
Good afternoon and welcome to the Pharmacy Podcast Network. My name is Ken Sternfeld and I am the host of PGX for Pharmacists. Welcome to the show. I want to take the opportunity to introduce our listeners to a very, very exciting and distinguished guest that we have on today's show. His name is Rupard and he's the CEO and founder of PGX. And I want to welcome Robbie to the show. Good morning, Robbie.
Hey, good morning, Ken. Thanks for having me.
Oh, it's our pleasure. Robbie and I hooked up a while back as we were doing our research and due diligence in the pharmacogenetic category on how we as pharmacists could get involved. And quite honestly, when we got to the point of talking to Robbie, we said we've landed the mother lode. We found a partner who we believe is perfectly aligned for pharmacists and the clinical applications and the data information that we get involved with as pharmacists from a clinical perspective to make an impact. So, Robbie, why don't you tell our listeners a little bit about how you got started and your associations with Georgia Tech, et cetera?
Sure. So ProGenix was founded about 4 years ago. I had in a prior life been chief operating officer for a medical device firm based at Georgia Tech, and we were an ATDC firm, which is part of the Advanced Development Center. It's an incubator program there at Tech, and I had left the device company and was really pondering my next move when I ran across the science related to pharmacogenetics testing. And I thought that it was quite interesting, and decided that we'd start a company there that focused on that. And so probably for the first year and a half, we spent money and learned, and we learned a lot about pharmacogenetics. And what we really learned was that there was a big need for, say, systemic deployment with respect to the testing. Not just a doctor-to-doctor approach, but to something that focused on the system because of the value, not just in the short run, but over an individual's entire life of having this information available when making prescribing decisions. So that was our first step that got us into the pharmacogenetics testing business.
So you took a very deep dive into it a number of years ago, and I guess the thing that impressed me most about your approach is the need for more data, the need to gather the information and to have it be ongoing. This is not even though it's a test you take once, but the changes that go on over the life of the patient mean for ongoing assessment and review. And your approach is really very unique in that regard.
So the data was everything, and being down there at Tech, everything is about data at Georgia Tech, and so we understood that there was a lot of value there, and as we investigated different market areas, whether you were looking at ACOs or MCOs or even just private practices, we realized that 4 years ago that there was a need for more data, more outcomes data, and more experiential data, sometimes which is just anecdotal. And so after spending a lot of time looking at that, we realized that the opportunity, at least to develop data and develop systems, was really in long-term care. And we were fortunate enough to begin the early stages of a development with Pharmaca for a relationship to deploy really as a differentiator for them into their client facilities. And we learned a ton about what it takes to deploy the product properly to clinicians because of this. And today we function in nearly 200 facilities like that.
Well, it's nice to know of your alliance with Pharmaca, because as pharmacists, we've seen, as we've investigated this category, there are a lot of, and I'll use this word, objectively, a lot of PGX peddlers out there, people who are putting the test into the marketplace, who really aren't firmly connected, as you have done, by making this test really something that lowers the costs while also improving the quality of care in a very systemic fashion. So can you speak to the lack of education of the industry about the testing process out there and who's doing it?
So I had to chuckle when you used the word test peddler, because it's one that we use. Oftentimes we'd see where some company had come through and tested first thing every patient in the facility in a nursing home. And, these reports in paper form are 15, 20 pages long. And so we just imagine the horror on the doctor's face when there's a stack of, say, 80 to 100 test reports that are all 15 pages each, and now they feel like that they needed to react to that. It's terrifying, because there's concerns about risk, and if there's information there that they need to know, very important, then they're going to have to spend a lot of time going through that, which this was a negative for a doctor.
So you would say that the lack of education at the clinician level was also an area that you addressed by offering them solutions that would probably reduce time, give them the opportunity to make actionable, do actionable changes in medication by really adapting to their lifestyle as clinicians.
That's the most important thing. I mean, we learned that if you were going to successfully deploy anything in healthcare, I mean, first thing, somebody else needs to pay for it. There's rarely any money around for anything. It needs to take a very small amount of time. In fact, it ought to give time back to the clinician in one way or the other. And then you want to make sure that there's real clinical relevance to the use of the outcomes. And we can talk later about how that happens. But and then physicians, if they're going to invest some time in it, there needs to be some improvement in clinical revenues, and we've learned how to support them in that as well. And so taking them to the genetic data and describing really something that we call context instead of content becomes very, very important in that education process.
And, when you talk about risk management, it really is so important, not just obvious clinical application, but there are liability aspects to having this test out there. And if the physician knew about it and didn't use it, and sadly, we live in a litigious society. So we are addressing a number of needs for the physicians by raising this awareness through education, communicating to them. To me, healthcare is about communication and delivering the message, educating them so that they can then give them the power, empower them to do what we know in our heart is the right thing to do in the first place.
So that's a great point, because the facilitation of communication between caregivers is a powerful, powerful thing. Today, we see, particularly in long-term care, that largely the consultant pharmacist and the nursing staff and the doctor all tend to operate in their own bubbles. Everyone has a job. These are production environments, and so people set about doing their jobs. But if you have something that facilitates more communication, then your risk management starts to actually work. And one of the things that we realized was, and coming out of the medical device field, we understood the difference between, say, a diagnostic tool and a clinical decision support tool. And pharmacogenetics is clearly a clinical decision support tool. So that having that information, the doctor still has control over whether or not they're going to make a change in the medication regimen of a patient. In fact, if one of the challenges that we saw early on was that doctors would say to us, okay, you gave me some really cool information. What do I do with it? And if the only answer that you have is, well, you need to change the medication, then you're dead in the water. And the reason is because there are a whole lot of other factors that have to be evaluated. And that's why they're a doctor. They've been to school for this stuff and they understand that. So maybe we don't change a medication. Maybe we adjust dosage. Or more importantly, maybe we take that information and we go back over to nursing staff and talk to nursing staff about potential things that need to be watched. So I'll give you a great example of this. So in the pharmacogenetics business, everybody can talk about the Plavix patient who was not properly metabolizing to an active form, or maybe a pain management solution, and it solved all the world's problems. But in long-term care and even in the geriatric environment, we see a lot of patients taking statins. Statins are problematic at times. They're sometimes you could argue that they're largely ineffective. They produce a lot of side effects, and those side effects all kind of work around, myopathy. And so you could say, okay, well, all right, so myopathy is a risk there. Well, yeah, but myopathy presents itself as a weakening of skeletal muscle. So we can go back to the nursing staff and say, hey, look, we've got these 6 or 7 patients here that are very, very, very high potential for increased myopathy symptoms, which means their fall risk is higher. And so when we start talking about context versus content, the content is the myopathy risk is higher, but how do you use it? And so then you take this information and package it up in a way that actually the whole care team can use it to improve outcomes, reduce risk, make things better for patients.
Robbie, you're talking about something and you're touching on something that just gets me crazy when I think about the perception of a pharmacist in healthcare. A lot of our listeners drive to work and listen to this podcast or all the podcasts on the network, so I won't ask them to raise their hand because it'll take it off the wheel as they're driving. But how many pharmacists, when they call a physician for a prior authorization, did the doctor say, just give them what's covered? I can't tell you how many times that's happened, and I wanted to jump through the phone and strangle them. Of course, working for certain organizations, if you did that, they'd probably fire you before they would say anything bad about the physician. But the point about intersecting that pharmacist into the care team, what I love about your model is the collaborative hub and spoke of communicating with caregivers. You put the pharmacist at the hub. We're not at the bottom of the barrel, not as a provider, someone who's just counting pills. We're someone who's critically important to the risk management and the analysis of this information that comes from this test. So we're not just dispensing. We're reviewing, assessing, using the clinical knowledge that we learned in school in the most important aspect, I believe, of pharmacy, which is lowering risk of adverse drug reactions, saving lives, and lowering the cost of healthcare. So just kudos to you. I mean, I can't tell you how wonderful it is that our team at RxVIP Concierge has decided to partner with you on a nationwide basis to make a difference in patient care.
Well, I appreciate that. Our first medical director, who was a former Special Forces doctor, all he did was talk about content versus context. And I'll be honest with you, for the first couple of years, we looked at him and said, what the heck is he talking about? But then as we began to really work in this market segment, we realized how valuable that was. And it is our primary focus to deliver context. And the pharmacist has to be the hub. Because you've got hands-on, all day long experience with high risk medications. And then we see in our, if the number of people taking 5 or more medications in the United States has tripled in the last 10 years. We have a serious problem with polypharmacy. There are genetic impacts that can have an impact on that. And then one of the things that we also wanted to do, we wanted to take away that 15 pages of reports. It needs to be available. It needs to be charted. But the doctor is looking for, what do I need to know, and how can I find it, and what do I do about it? And so we have a technology partner that is just absolutely fantastic that worked with us to develop our technology tools that condense that 15-page report sometimes into a single red flag. And the caregiver provider, whether it's a doctor or a nurse practitioner or physician's assistant, or the consulting pharmacist in the facility, or the pharmacist in the retail location, can look in there, take a quick peek, and see whether or not we have a problem. And the one thing that we ended up doing that was the real game changer with respect to Pharmaca is that today, Progenics has a real-time data feed between the Pharmaca pharmacy, their industrial pharmacies, and Progenics in the client facility. So as you mentioned earlier, this isn't just a one-time, one-and-done test. Yes, we do evaluate what they're taking right now, but what's really important and has been demonstrated by numerous white papers is the value of actually preemptive use of this data to prescribe medication. Suggests that $600 or $700 a year in medication savings by itself.
With those facilities that you're working with, approximately how many patient lives are you impacting with this real-time data that clinicians can make actionable changes in medication on?
So I think the number of patients that actually we have a data feed on is about 26,000. Now, I mentioned before, we don't believe in testing everybody in the facility. We think that's volume driven. We have specific algorithms that are constantly evaluating those individuals, and as they have medications that cross up with statistical relevance for high risk and potential problems. So we have a scale that we use for that. Or if they just match up with, X number of high risk medications, then that kind of flags them for testing. So, it's interesting. We've got about 26,000 patients we watch. We probably have 7,000 or 8,000 that we actually run the pharmacogenetic data on. And then, I don't know, we probably collect 1.4 million, 1.5 million data points a month on pharmacy in the geriatric space for long-term care.
And you talked about your technology partner, and I believe technology, of course, is a needed component and supports everything that there is in healthcare, but it's still about the people, and it's about that clinician who has the opportunity to use that technology, access it, and then act on it. You created a portal, a ProgenX portal that a pharmacist, instead of driving X number of hours to do a 10-hour shift, could actually be involved in the clinical assessment through a online portal. Can you speak a little bit about how those pharmacists would be able to be involved down the road in this kind of initiative?
So a pharmacist, for example, and I'll just use our Pharmaca relationship because it's a great example. So they have consultant pharmacists who visit facilities once a month, and yet new medications are prescribed every week. And so we have a notification system. So let's say, for example, we have a patient that's a poor metabolizer of 2C19, and they are actually prescribed Plavix for one reason or another, maybe a new DVT diagnosis or something like that. If that happens, that actually creates an alarm in our system, an alert in our system. And that alert is pushed out to the pharmacist. And the pharmacist, no matter where they are, is able to access a HIPAA-compliant, cloud-based portal to see what that alert is. and then interface with whatever consulting software that they use to send an alert to the physician. And at the same time, the Progenics clinical team is notifying physicians if there's a big problem that needs to be reacted to. In the nursing home, the director of nursing, assistant director of nursing, both of them are notified. Let's watch for side effects of certain things and a variety of other things. So really what it does is create a one-of-a-kind, really real-time alarm system that the pharmacist has access to without driving to the facility.
That's great. You're a recognized leader, your company, in the long-term care area because of these risk management solutions that you've incorporated. And we are going to look to grow that with you because we have some contacts in those areas as well. But we'd also like to expand what you do to make it more universal effectively for more pharmacists to get involved and utilize the great tools you have. So, our concierge approach to pharmacy, which is kind of taking a day off from retail and acting like a provider and providing these services, is something that Jason Cavallino, the president of RxVIP, has been working with you on to develop a strategy nationwide where we can deliver the great tools, the great resources, and the ability for a pharmacist to practice at the height of his or her license in a more effective manner. And we're interested in growing into more ambulatory care, other hospitals, other areas, and we're fortunate enough that you're actively looking to work with us on that, and all the pharmacists who are listening in.
Well, and one of the ways that you do that today, as healthcare has made a transition from volume-based healthcare to value-based healthcare, we're seeing lots of new value-based models. So we see the ACOs, the MCOs, integrated delivery networks, and today, one of our goals is that we need to make the cost of this testing the lowest possible number that we can do, because then we can begin to cover more and more people at a lower cost. And there are a number of different outcomes improvement and cost saving strategies that using this information across large patient populations. And that's probably why our data, the amount of data that we collect today is so valuable, because we have learned, we understand where our opportunities to reduce antidepressant, antipsychotic type of medications and get on to ones that actually work. There are lots of problems with SSRIs. We find ways to provide physicians actually with the tool that they need to even convince their patient that they don't need this medication, for example. And so taking that type of holistic approach and systemic approach to ACOs and MCOs, integrated delivery networks, and going to them and showing them that there's ways to integrate this information, focus back to the pharmacist, so that the pharmacist is once again recognized as a valuable member of the whole care team. Then and then even marrying our data up to proper formularies will give us an opportunity to cut costs, deliver better outcomes, and do it in a way that works for everyone without creating a whole bunch of log jams in a number of places.
Absolutely. And the other thing that Jason uncovered in his dialogue with you is the chronic conditions that so many Americans on Medicare suffer with, and the cost factors for chronic care management. Medicare has invested a tremendous amount of money into that program, which is an indirect non-face-to-face model where a pharmacist can be involved and a pharmacy team can be involved as well, because that segment of the population really is taking the largest amount of medications. And if we can improve the patient response in that area, we can certainly lower the cost of healthcare and also be compensated for the services that we deliver. So I think the combination of what you've delivered and the fact that we feel that the pharmacist can be that provider, and that's a word that we really look for because we are providers when we do this, really makes the opportunity for pharmacists special by looking at the Progenics model. So I want to thank you, Robbie, for the time. I know Sundays, we're recording this on Sunday. It'll be broadcast, any time that anybody listens, but you're a golfer and you probably might have taken some time off from teeing up. So I wanted to thank you very, very much.
It's raining pretty hard here today, so we're skipping the golf, but I think my honey-do list is pretty big.
I have one as well, and I really want to thank you. And please, that's 3 pleases, be a regular visitor to our show, because I know the response to our listeners on this show will be extraordinary. I'm going to include an article that you sent over just before the show that is going to be posted on PharMerica, that they listed about helping improve quality of care and reducing costs. At the same time, I think it speaks towards a number of the things that you're talking about, and I think our listeners would be very much interested in seeing that. And please feel free to forward any other information on your company and your vision to us, and we'll be happy to expand on it as well.
Thank you so much. And Ken, you guys are doing a great job. And one thing I'll say is it's clear to us that your heart's in the right place. And in healthcare, you don't get a whole lot of rewards. So if your heart's not in it, you can't be in it. We find that in long-term care. We appreciate you guys and really what you're doing, and we'll be glad to be a regular guest as you'd like.
Thank you. Well, I had a little red heart on my lab coat when I worked for a major retailer, but I really appreciate that comment, because all of our team members really are compassionate and passionate about this vision of what we do. So thank you for those kind words, Robbie. I truly appreciate it. Thank you, all our listeners. I wanted to thank you for taking the time as well to listen to PGX for Pharmacists on the Pharmacy Podcast Network at PGX4RX. Please send us questions, comments, anything you want. We're here to serve. Have a wonderful day, and we'll see you next time.